I'm Bruno Steiner. I'm the president of the Imaging Special Interest Group for the American Physical Therapy Association's Academy of Orthopedic Physical Therapy.
Nailed it. You got it right.
Right. It only took 7 takes.
So beyond special interest group, I remember as a student, someone saying the word SIG and me being like, I don't understand what that is. And then I understood what the acronym meant, which is special interest group, right?
Yeah.
Deeper than that, how do you explain what the imaging SIG, the imaging special interest group within the Academy of Orthopedic PT, what does it do? What does it exist for? Who does it exist for? How do you explain that?
Like I said, there's a lot to unpack. What does the SIG do? I came out, why don't I give you the story of how I came to it? I didn't know it existed. It's somewhat of a buried entity within the Academy of Orthopedic Physical Therapy, but I came to find out about it when I adopted a musculoskeletal ultrasound, with the diagnostic musculoskeletal ultrasonography. And we finally got the permission, or rather, we finally realized we could use this as our very own imaging modality. And I was looking for all kinds of literature on it, looking for any sort of class you could take on it. And it's very much the Wild West. It's just really this technology and application in musculoskeletal diagnostics was in its infancy. And so when I started learning it, to my glee, realizing this is a game changer for physical therapy and imaging referral in general. And and oddly enough, at one point there was a little pushback against physical therapists learning this at the level of the American Registry of Diagnostic Medical Sonographers. And I found out that very much behind defending our right to actually pursue musculoskeletal ultrasonography was the then president, Doug White, of the Special Interest Group dealing with imaging within the AOPT. And he did such an amazing job at securing us a position at the table and getting us to actually pass the physician's credential, which is the RMSK, of which I am an RMSK right now. And if it wasn't for the imaging SIG, this wouldn't have happened. So this was a small engine with a titanic force behind it. So I said, I have to be part of this. I have to at least support it and make sure I'm up on what they're doing, because I think some smart people going through that SIG. And, if you don't support something, things can be taken away from you. That's what I've learned in the practice of physical therapy. So I said, I jealously guarded the fact that we were able to do this and sit for this physician's exam. And on top of that, they managed to basically get us recognition from the American Institute of Ultrasound and Medicine that physical therapists are recognized as licensed medical providers of MSKUS. Think about it. Licensed medical providers of MSKUS. So they realize we have the chops, we can do this, we have the educational backgrounds, we can embrace this. But we're getting institutional recognition, and that was like marvelous. So I said, now that we got it, we have to sit the exam. We've got to get as many physical therapists as I can to use this modality, and frankly, go toe to toe with everybody else who wants to take the exam and show that we can pass it. And you know what? We are. And we are doing it in great numbers. So it's so exciting. But with that, I said, I have to guard this. So whenever somebody asked to do a lecture or a speaking engagement, I was at the ready. And what happened was with then Charles Hazel, another great president for the imaging SIG. He asked me to do some webinars, content for the AIUM. And that's a big thing, because, when the physician sees that we're doing this type of content and taking really, really great, elegant imaging, it can no longer be denied. So we've created these amazing partnerships with Intellios, these credentialing bodies, and AIUM. And we just wanted to maintain it. But then, eventually people realize you're a bit of a zealot, and then they ask you to run for something, and then and you go like, oh crap, I got to. You got to do it.
You wound up opening your mouth, and you had to walk the walk after you talk the talk.
Yeah, and for some crazy reason, they asked me to run for president, and so I did it and learned a lot more about what imaging means to physical therapy and what it means, frankly, for our professional relevance going forward. So not only performing MSKUS, which is crucial. I mean, this is it's going to be the bedrock of our profession, but also to have now that we're recognized as primary care providers ourselves, because we have in most states a real direct access. Well, we have to have access to other diagnostic testing, which
Right.
we are very well equipped to perform. So a PT-directed imaging referral. So realizing that that's also absolute critical development in physical therapy care and, frankly, public health. So this is our focus, and we're expanding um, just our I would say at least our breadth. Uh, we're still a group that has to perform a lot of outreach, and people still have to find out about us, and we're hoping you can help.
That's what I'm here for.
Right, I know, I can
Well,
tell.
well, before we started speaking, I knew a very little bit. I knew what I read on the website,
Yeah.
right? But it sounds like even after the first 5 minutes of us talking, after you responding to just one question, it sounds like you've got a special interest group made of people who are passionate, who are advocates, who want to pursue and advance an area of our profession that's really important to them. You get those people together in a room or in a group, right? That's what a special interest group is for, is get
Right.
those people together, and it looks like stuff happens.
Yeah, and particularly when people collaborate. So be willing to have that chat. Be willing to get in front of somebody else, exchange the ideas. Realize that this is a type of endeavor. Whether you're seeking imaging referral privileges in your state, you really need to have some game prep. Luck favors the prepared.
Yeah.
And what we're noticing is is those who prepare really well get really, really great results. And that's what we're there for. But you have to use our resources too.
Right.
So I often tell people who, when I reach out to people and realize, oh my God, they're about to do a legislative attempt or a state board ruling attempt. Hey, I'm not out to hijack your process. You know your state. But I got to tell you, there's a lot of similarities in terms of how to approach a state board or a legislature. So we got those resources, and we've done some exhaustive review of current evidence that favors physical therapy, in the realm of imaging. The evidence it's impressive. I mean, when I got to the I-SIG as the president, I was just going, okay, where are we when it comes to imaging? What do we need to do?
Right.
And I said, so I looked at all the evidence and went like, oh my God, we've already got the compelling evidence here. We just have to package it in a way that people can use it as a legislative guide, or, it's overwhelming. Any argument you can throw at me, I can counter it and say, that's wrong. Actually, we have this,
Wow. So that's also a big deal, right? So having it or it being known, and I'm using air quotes just in case people listen on the podcast, it being known is good. But unless someone can access it, knows when to use it, and knows when to use that information or how to use that information, without that, it's almost useless.
Yeah, and returning back to the concept of collaboration, reach out. Don't reinvent the wheel on this.
Right.
We're not here to direct you. We're here to support you. In any negotiation, you have to have current evidence, if you're dealing with stakeholders that might be, actually, let's face it, the whole concept of stakeholder is that these are people who care about an issue. But what happens if the stakeholders you're dealing with really are combatants, and frankly are dealing with turf and potentially conflating mischaracterizations. You have to be equipped to handle any objection, any concern. You're also there to validate the people's concern, but you have to have the evidence that basically dispels myth and things that just don't reflect the current realities of our education and our profession. So get prepared. So what's really great, working with Justin Elliott and Governmental Affairs VP and Daniel Markhouse, who unfortunately just left us for another job opportunity in Utah. He was greatly helpful. They'll find out about things. They'll refer to me, and I will do some outreach. Sometimes people reach out, but really, we really need people to if you're entertaining an idea, if you're just thinking about it, if you just want to hash some stuff out, call us, call me. I consider us a bit of a rapid response team. With all our people have really been thoughtful about this and have some very good, you know, tactics is maybe a little too brutal a term, but the fact is the evidence is there. Physical therapists are well suited to fill this role. But case in point, we had just this enormous victory just in the last couple of months. I was talking with, I had the pleasure of talking with APTA chapter president from Iowa, Corey Zimney, who with his team spearheaded this legislative attempt to getting full access to imaging privileges. He thought it was going to take 3 to 4 years, but Corey, who is a master prepper when it comes to this, did his homework. He called us up. We gave him resources. We talked out the idea, and his level of mastery was breathtaking, and because he prepped. I mean, he really prepped. He had all the arguments. So because of this effort, he was yet another one of the states that got full direct imaging access. So we have 7 states now that have unfettered access to imaging referral, and 4 other states that are limited to just radiography, x-rays. Now, what's really funny in those 4 states, they're letting us refer people for ionizing radiation, but they're not going to let us use MRI. It's patently ridiculous. So you're going like, wait a second, is this a patient safety issue? Because cost is really weird. Because we're shown, again, the evidence shows that actually the sooner we get involved in a patient's care, far less cost associated, a lot less unnecessary imaging ordering. Why? Because we know what to do with these cases. We're better at it than really we're maybe second only to orthopedic surgeons. So, and this is what the current evidence shows. I'm not inventing this stuff. So it's exciting. But I love reaching out and saying, hi, I'm Bruno Steiner. Glad to meet you. But it would be nice when people have any questions, call us directly, call me directly, send me an email. We are open for business. So we want to see this. We want to see all states have this advance. It's great for public health. It's great for our profession.
Love it. Let's look to a different topic,
Sure.
And they're all about acronyms. We don't have nearly enough acronyms in physical therapy or healthcare in general. We love it. MSKUS and the RMSK. Let's go with the first one first. If someone hasn't seen the acronym, chances are they probably heard of what it actually means. But let's talk about the opportunities in terms of that imaging modality. So just like, how would you explain it maybe to a new career professional, maybe a PT student who's not familiar with it? Let's talk about what MSKUS is.
So MSKUS, as the general community of sonographers, medical doctors, medical professionals, it simply means diagnostic musculoskeletal ultrasonography. So you're using it as MSKUS refers to imaging, and considering physical therapists have always used ultrasounds, I mean, we're born with them in our hands at therapeutic levels, really high energy stuff. MSKUS involves an incredibly small package of sound to reflect into the tissues, come back to you and provide an image. I often tell people, our fishermen with their fish finder devices are basically kind of lakeside ultrasonographers. So physical therapists need an imaging modality because we do so much diagnostics. and it's so safe. There's no ionizing radiation. There's no concerns, and we're so musculoskeletally educated. This winds up being the ideal extension of our physical exam. So it gives us an additional layer of clarity whenever we're determining the extent of an injury, how fresh the injury is, whether you're dealing with hematomas, how ripped a tendon is, and that extra bit of information is going to let you plan a treatment that much better. It will let you track the progress of the patient's healing and mending into the tissues. I mean, and physical therapists use this so much differently because we want to look at impingements that are happening. We want to see, well, why is the range blocked? Is there a bony block? Well, is there a loose body? Are there other intra-articular impediments? What are we dealing with? Are we dealing with the myositis ossificans traumatica? This stuff is so easily seen. And how many times, you have physical therapists go like, we're rendered fearful of any sort of calf thing. So we're going like, shoot, what is it? And we don't have much of a test for it, right? There's home inside. Yeah, whoop. I mean, that can easily be confused for a calf tear, or maybe you've got a ruptured Baker's cyst. I've picked up on those. I've picked up on calf tears, ruled out DVTs. So this is unbelievable in terms of differential diagnostics or screening. How valuable is that? Instead of making a patient wait for weeks on end to go to their primary care physician, who's only going to refer them to the orthopedist, who's then going to refer for an MRI or a whatever, and you're just, come on. We can, with this technology, and you can do your evaluation, leave the machine on, do the images, get good at it, and then all of a sudden, you have a game plan right away. This is the beauty of point of care ultrasonography. So when we think of MSKUS, it's a point of care tool that we can use, and we're so well suited to it. Now, when it comes to an RMSK, so the RMSK is an interesting development. So physicians under the mother corporation Intellios, who also governs the POCUS Academy, and there's another one of those what are they called? Not aphorisms, whatever, abbreviations. So the APCA, out of Intellios, because of physicians' wants and demands, they wanted to have something that was specifically attesting physicians. They didn't want to be lumped in with the sonographers, with the American Registry of Diagnostic Medical Sonography. So they wanted something different. They wanted an APCA, the Alliance for Physician Certification. And physical therapists happen to, again, because of the work of the imaging SIG, and then President Doug White, made the APCA realize physical therapists must do the physician credentialization. So RMSK is the Registered Diagnostic Musculoskeletal Ultrasonographer. It's the physician's certification. And luckily, and frankly, logically, we are taking the same exam as physicians, whether they're physical med, whether they're chiropractors, whether they are orthopedists. We're taking the exam, and we're doing great. We're really doing great at it. So this is when when people learn, when physical therapists say, well, I want to learn it, but I don't know if I want to do the RMSK. No, you want to do the RMSK. You're going to learn the same stuff anyways. You might as well take an exam in it. And the credential is going to give you just a mind-blasting advantage in your career, especially if you're young. I'm 60 now. I started when I was 52. I was like, oh my God, I can imagine if I started this 20 years ago. So it's in its infancy. And I just tell physical therapists, if they want to do any sort of real grassroots advocacy for imaging, learn MSKUS, do the RMSK, and let's as my good colleague Jim Dauber says from Marshall University, let's pack the room, and we own this. But the genie's out of the bottle. We have the institutional support on this, but we can't take this for granted. That's why I'm the president of the Imaging SIG, because I don't take anything for granted. We need to move the ball forward for our patients and for us and for healthcare in general.
So there's a crisis. I'm going to throw that out there. It's something that's come up, right?
Yep.
So let's help the people listening or watching understand what the crisis is and how we are or could be a solution, and what we use to back that up. Sounds like a homework assignment, right? There's a problem. Let's help outline if we are the solution or part of a big part of the solution, and then how we prove that. So first, let's start with the crisis. What is it? How can we understand it?
Healthcare has always been a hot button issue. Health equity is now a hot button issue. We're not serving our rural communities, not adequately. There are many communities that are not getting served properly. And to exacerbate this, there's really significant shortfalls in physicians and nursing. And this isn't just a COVID thing. This has been happening. And it is critical right now, and it is going to get worse. And as my good friend and colleague Lance Mabry, who wrote a seminal work recently showing the physical therapists do actually have the abilities and to practice imaging referral. He notes that stating this diplomatically, he notes that musculoskeletal care will suffer in this scenario. Not for just the obvious reasons that, oh, there's not enough physicians to go around. But musculoskeletal care is a complicated business. And the idea that, Lance mentions, nurse practitioners and PAs are now summoned to potentially fill a role to meet these shortfalls. But it really isn't meeting critical musculoskeletal care because unfortunately the data shows that they're not necessarily the best at referring. There have been studies that show overutilization and inappropriate imaging referral. So this is where physical therapists come in. The evidence shows that physical therapists are actually really good at this, and we can step in and help out help with these terrible bottlenecks, whether it's in urban or rural communities. The evidence is very clear that we order imaging far less because, frankly, we order it appropriately, and when we order it, we are far more adherent to the American College of Radiology guidelines than other professions. So we're really observant of this. So this is where we can actually step in. We're begging to step in and assume our role that we should be taking. And, there's precedent for this. It's not like we're just inventing this. The military branches of physical therapists actually refer for imaging. And the orthopedic surgeons really like this because by the time they get a referral, number one, they've been vetted, they've been evaluated by a physical therapist, they've been treated by a physical therapist. If that doesn't work and the conservative approach isn't working, send them for appropriate imaging, and then with that bundling of information, send it to the next person who may have other options. So by the time, and Jim Dauber will tell you this, having worked in the military branches, the orthopedists loved it because they didn't have to make the extra referral and waste time. They had all the evidence. They can make their determinations right away. So, we've been doing this since the 70s. So all we're trying to do right now is expedite care and leverage the talents of the physical therapists that are frankly that are the most. I just feel like we're the most underleveraged profession there is, with so much talent, so much smarts. I mean, I don't know if you got that sense at CSM in San Diego, how young people were and how dedicated and zealous and really wanting to make a difference in healthcare and for their patients. So I can't just talk about a profession that is ready to fully realize what already has been practiced, frankly, since the 70s.
Well said. One thing I want you to look forward to the future. We've talked a lot about the past, what got you here, what's going on now. That's the present. How about the future? You talked a little bit about of not going into something if you're a state association without doing your homework. And there's something that's coming out in terms of a legislative guide for physical therapy imaging advocacy. Can you give us a little preview on what that would be, who it's great for, what they'll get to do with it?
Yeah, we've trial ballooned it with a couple of states now who want to keep their cards close to their chest and just to disseminate what we've written. So the idea was, it's very difficult for physical therapists to do a lot of research, especially, you know how it is.
Sure.
You're treating 30 patients or however patients you have. You come home, there's barely any time for life work balance, and then you want to make an initiative. There's no time to collect all this evidence. So the idea was, we have to weaponize people to have the best arguments and really have the evidence right at their fingertips. So the idea was, okay, let's make it easy and let's make it uniform. So here's a document with an exhaustively referenced body of evidence, background, and with a lot of arguments against, frankly, boilerplate arguments why we shouldn't have this. And so we essentially counter every objection that I've managed to glean for the last few years. And it's done in a tidy form, easily referenced, easy to leaf through. And so far, the feedback has been marvelous. So I am extremely close, if not like a whisper close, to actually getting this reviewed by the AOPT leadership and APTA. Talked with Justin Elliott about it, and it's an impressive document. Not impressive as in terms of being unusable, but impressive that it really addresses all the objections and gives everybody that historic precedent as to what, why we should be using this. So the idea is, come to us. We'll have it available to you. And let's chat about your approach. Let's see what your Practice Act says. And let's just collaborate. Let's just chat about it. Let's riff some ideas and move forward. What we're finding really interesting is in terms of laying the groundwork to this type of initiative. We found some great ideas as well. But for that, you're going to have to call me.
Love it. Now, as the president of I-SIG, I didn't prepare you for this, but if you had the ear of people listening and paying attention right now, why should they become a member of the Orthopedic Academy and eventually your special interest group? What would you say to someone if you had their ear for a few seconds and were able to make your pitch?
The pitch is PT-directed imaging referral as an issue is the direct access issue of our time. It is absolutely the most important thing, I think, out there. I know billing is a big thing, but this is the issue that will give us professional relevance, will assure our professional credibility. And if you want to be involved in anything, this is the one thing, because it's going to, once this is passed, and once our colleagues, physician colleagues, nurse practitioner colleagues, PA practitioner colleagues, you name it, when they realize what we can do, when they finally realize what we have been doing, they're going to have an awakening, and this will foster much greater collaborations down the road, and frankly make everything else we want to attain in our professional careers possible. I lump in that the importance of MSKUS. So if you want to make a difference, this is the next step for our profession. I really think this is the most important. And the more prepared you are, the better you will be able to counter any ridiculous argument as to the contrary. And that's why, you have to talk with people who are in at the front, at the tip of the spear, and really get familiar with the subject. It's not easy, but it's once you get all the evidence, it's actually, you'll be able to talk the talk and then walk the walk. So it's important. I invite everybody to join the I-SIG. We have some robust numbers, but we want more. We want to be a force, and we want to move this forward because, I'll give you an example. Here's a really cool thing. So I'm very proud of any sort of legislative attempt that gets us dry needling, for instance. But now, and physical therapists are good at anatomy, but imagine this. You can now do it under guidance of ultrasound to know exactly the tissue you want to hit, and safely without ionizing radiation. Oh my God. So here's this one thing that has enormous application and just improve the quality of our treatments. So, I mean, I can't even imagine the synergies that'll develop when we have this, whether we want to be associates in a private practice or an orthopedic clinic. I'm not talking about as an employee. I'm talking about a partner. So to me, it's mind blasting. The possibilities are just crazy. So we just join the I-SIG, be part of it.
Well said. It's a great pitch.
Thanks.
Is there anything I didn't get a chance to ask, or anything you didn't say or mention, I should say, and I want to make sure that's open before we wrap up. But
look, it's impossible to get everything in.
Yeah.
It's all I could, yeah, why not this?
Go ahead.
So this is the funny thing. One of the arguments against, I'm going to give the argument against, okay? I said, yeah, we're good at musculoskeletal stuff, probably a bit better than other people. No, way better. But yeah, we do learn radiology in our courses, but it's just not standard across the state, meaning there's no, it's not uniform across nationwide. That's it. Okay, so the argument is, yeah, we're pretty good at musculoskeletal, but yeah, and we do learn radiology, but it's not uniformly taught across the nation. And this is how physical therapists shoot themselves in the foot. And I'll explain. And this is really important. So CMS and other payers recognize nurse practitioners and physician's assistants, as well as clinical psychologists, to be providers of referral of radiology referral. They have no mandated radiology study in their curricula. None. We are the only ones that explicitly demand of our doctorates that there be radiology taught. I mean, we check that. We have to check that box off according to CAPD. We're the only ones that do that. So when we argue against ourselves, saying, oh, it's not uniformly taught. No, but we're mandated to talk about it and do it. And frankly, physical therapists always get involved. And we're always telling primary care providers, well, what we'd like to have ordered. I work with hematologists, oncologists. You heard the term, the cancer doctors. They ask me what to do in terms of referral. I'm the one that does MSKUS to help guide treatment as well. So the idea of that false narrative, just lose it, because it's not fair. We're being excluded from something we're really good at. So we can't use this silly argument when other professions, frankly, have no standard. So let's get real here. Just let's get real. Let's stop it. If you have a fear of referral for radiography, fine. But don't impose the fear on other people. They could just be, live and let live. That's what I want to say.
Bruno, appreciate the time. Thanks for the insight. Thanks for doing what you do on behalf of the Academy and the profession and the physical therapists who are in it and the patients eventually that will get to help because of it.
Yeah. Thank you for doing this as well. And please feel free to call and check up on us whenever you want, and let everybody else know they can call and check up on us.